Welcome. In this session, we'll be discussing about choroidal dystrophies. Choroidal dystrophies, being inherited disorders, are bilateral and symmetric, in which retinal pigment epithelium is considered to play an important role, if not a pivotal role, in pathogenesis. In contradiction to the name of this group of disorders, the choroidal circulation is not considered to be the primary site of pathogenesis. Choroidal dystrophies are progressive disorders typically showing degenerative changes in the retinal pigment epithelium in the early stages, and choriocapillaris, retina, and larger choroidal blood vessels are affected as a consequence of RPE damage only in the later stages of these entities. In their early stages, these entities have characteristic fundus findings, but later in the disease process, the fundus findings may overlap between the different entities. Choroidal dystrophies are classified into regional and generalized choroidal dystrophies. Regional choroidal dystrophies start as geographically confined disorders which may progressively expand to involve more extensive regions of the fundus, and these disorders initially present with loss of central vision if affecting the macula, such as in central areolar choroidal dystrophy and bifocal choroidal atrophy. Central areolar choroidal dystrophy, or CACD, is a disorder which is mostly autosomal dominant in mode of inheritance and occurs due to mutations in PRPH2, GUCY2D, or GUCA1A gene. We may recall here that mutation in PRPH2 gene is also implicated in the causation of pattern macular dystrophy, which we have discussed in the previous session. Also, each of these three genes are expressed in the photoreceptors. Patients with CACD present with loss of central vision in late second to early fourth decade of life, and fundus examination shows a solitary well-defined circular or oval atrophic area in the center of the macula in the absence of flecks or drusen's. This absence of flecks differentiates CACD from autosomal recessive Stargardt's macular dystrophy. In CACD, early on, there is only RPE mottling in the center of the macula as seen here in this photograph. Later, RPE and choriocapillaris atrophy, resulting in increased visibility of underlying larger choroidal blood vessels as seen here in this clinical photograph. And in advanced stages, the larger choroidal blood vessels also degenerate, resulting in a white appearance due to visualization or exposure of the underlying sclera. Fluorescent angiography prior to choriocapillaris atrophy shows transmission hyperfluorescence due to atrophy of the overlying retinal pigment epithelium as seen here in this fluorescent angiogram, and following choriocapillaris atrophy, the hyperfluorescence disappears as seen here in this fluorescent angiogram, and fluorescence from the larger choroidal blood vessels become more prominent. Leakage from intact choriocapillaris can be found at the margin of the atrophic area. Full field ERG is typically normal, and visual field testing shows a central scotoma. Fundus autofluorescence shows hypoautofluorescence from the involved area as seen here in this image due to absence of RPE and its lipofuscin, and OCT shows atrophy of outer retina, RPE, and choroid in the affected area with resultant increased hyperreflectivity from the sclera. Differential diagnosis of CACD includes Stargardt's disease, which is autosomal recessive and have flecks surrounding the atrophic area, geographic atrophy of age-related macular degeneration, which typically shows multiple drusen surrounding the atrophic area, North Carolina macular dystrophy, which is characterized by a congenital non-progressive excavation in the center of the macula, pattern dystrophy, and cone dystrophy, which shows abnormalities in photopic responses on full field ERG. Peripapillary choroidal dystrophy is an autosomal recessive disorder which initially involves the peripapillary area as seen here in this color photograph, and then progresses centrifugally along the arcades and also towards and ultimately involving the fovea, and only when the fovea is involved, the patient complains of loss of central vision. Full field ERG is usually normal in this condition. Differential diagnosis of peripapillary choroidal dystrophy includes atrophia areata, which we have discussed in the previous session on macular dystrophy, serpiginous choroidopathy, which we have discussed in the uveitis section, and pigmented paravenous retinochoroidal atrophy, which we have discussed in the session on retinitis pigmentosa and allied disorders. The third regional choroidal dystrophy is progressive bifocal chorioretinal atrophy, which is an autosomal dominant disorder. Patients with PBCRA present with poor vision, nystagmus and photophobia as the macula is involved since birth. PBCRA is characterized by two foci of chorioretinal atrophy, with one being a congenital large central macular atrophy as seen here in this clinical photograph, and the second being an area of atrophy nasal to the optic disc as seen here in this clinical photograph, which appears in the first to second decades of life. These two areas of atrophy enlarge and ultimately leaves only a vertical region of normal retina and choroid confluent with the optic disc. ERG shows significant abnormalities in both rod and cone responses, particularly in later stages of PBCRA, and PBCRA is associated with a high incidence of retinal detachment. Generalized choroidal dystrophies involve most of the fundus even in their early stages and then progress in severity, and patients with generalized choroidal dystrophies present initially with nyctalopia, with loss of central vision occurring much later in the disease process. The generalized choroidal dystrophies include diffuse choroidal dystrophy, gyrate atrophy of the choroid and retina, choroideremia, and Bietti crystalline dystrophy. And as we shall see, the fundus signs of gyrate atrophy of the choroid and retina and choroideremia overlap. Diffuse choroidal dystrophy is usually an autosomal dominant condition characterized by diffuse atrophy of the retinal pigment epithelium and choriocapillaries, and mutations of PRPH2 gene has been found in some patients with diffuse choroidal dystrophy. Patients with diffuse choroidal dystrophy present with either central visual loss or nyctalopia or both in 4th or 5th decades of life, and early changes include RPE mottling and hypopigmentation, and later diffuse atrophy of RPE and choriocapillaries occur as seen here in this photograph. The larger choroidal vessels become more distinct and prominent, and some of these choroidal vessels may appear as yellowish white bands. The posterior pole and the periphery are affected to varying extents, and peripheral pigment clumps may appear later in the disease, but the appearance of the retinal vessels remain normal. Full-field ERG is subnormal to extinguished in diffuse choroidal dystrophy, and on fluorescent angiogram, the medium and large choroidal vessels appear prominent throughout the fundus because of loss of choriocapillaries and retinal pigment epithelium, but residual islands of choriocapillaries may appear as patchy areas of choroidal flush, and visual field testing shows peripheral constriction. Gyrate atrophy of the choroid and retina is an autosomal recessive disorder which occurs due to mutation in the OAT gene, which encodes ornithine delta aminotransferase or OAT enzyme, which converts ornithine to glutamate. The OAT enzyme uses vitamin B6 or pyridoxine as a coenzyme, and this is therapeutically important. Because of deficiency in ornithine aminotransferase, serum ornithine levels are increased in patients with gyrate atrophy of the choroid and retina, sometimes to 10 to 15 times its normal levels. The RPE cells are the earliest to become affected in gyrate atrophy, followed by atrophy of the photoreceptors and choriocapillaries, and it has been found that intravitreal injection of L-ornithine in experimental animals caused deterioration of RPE cells in a patchy distribution. Patients with gyrate atrophy of the choroid and retina present in 2nd to 3rd decade of life with nyctalopia and loss of peripheral visual field, but visual acuity is affected only later in the disease process. Early in the disease, large areas of RPE and choriocapillaries atrophy develop in peripheral and mid-peripheral fundus as seen here in this clinical photograph. The affected areas are very well defined and geographic in appearance. Pigment clumping can occur at the margins of these areas. These areas enlarge both centrally and peripherally and also coalesce with each other, and the junction between normal and abnormal zones appear typically scalloped. And the retinal pigment epithelium in areas of unaffected fundus usually appears hyperpigmented. Later in the disease, there is total choroidal atrophy in the affected areas, which then appear white because of exposure of the underlying sclera, but the macula appears clinically spared. Cystoid macular edema has been reported in this condition, and myopia, posterior subcapsular cataracts, posterior vitreous detachment, and epiretinal membranes are associated features of this condition. Visual field testing shows concentric peripheral constriction early in the disease, and in later stages, paracentral and central scotomas may also be found. In well-established disease, full-field ERG shows attenuation of both rod and cone responses, with the rod responses being affected more severely than cones, but in later stages, the ERG is completely attenuated. Fluorescent angiography shows transmission hyperfluorescence in areas where only RP is atrophic, or hyperfluorescence with prominent choroidal vessels, as seen here in this angiogram, where both RP and choriocapillaries are atrophic. And dark adaptation testing shows elevation of both cone and rod thresholds. And on fundus autofluorescence, the affected areas will show hypoautofluorescence because of atrophy of RP and its lipofuscin. Gyrate atrophy patients also show abnormalities in muscle biopsy, mitochondrial appearance in various ocular tissues, electromyography, electrocardiography, and electroencephalography. As ornithine is synthesized in the body from arginine, an arginine-restricted diet is recommended for patients with gyrate atrophy of the choroid and retina, and it has been seen that arginine-restricted diet decreases the rate of progression of chorioretinal atrophy in these patients. So a rigid low-protein diet with near total elimination of arginine along with supplementation with essential amino acids is recommended for these patients. And upon therapy with vitamin B6, some patients with gyrate atrophy respond by reduction of serum ornithine levels, but other patients of gyrate atrophy do not, based on which gyrate atrophy has been divided into two types. And vitamin B6 responsive patients have been found to have a milder disease with better preservation of visual function, electrophysiological responses, and dark adaptation responses as compared to patients who do not respond to vitamin B6. Cataract surgery is often required early in life in patients with gyrate atrophy of the choroid and retina, and incidental CME in these patients should also be treated. Choroideremia is an X-linked recessive disorder due to mutation in CHM or RDP1 gene, which encodes Rab escort protein 1. Rab escort proteins play a role in post-translational modification of Rab proteins. The Rab proteins regulate intracellular trafficking of lipid membrane-bound vesicles, including those in the photoreceptors and retinal pigment epithelium. And this post-translational modification of Rab proteins, facilitated by Rab escort proteins, are required before the Rab proteins can attach to lipid membranes of vesicles. The incidence of choroideremia is 1 in 50,000 individuals. Like other choroidal dystrophies, initially RP atrophy occurs in choroideremia, followed by atrophy of photoreceptors and then choriocapillaries. And in well-established disease, extensive atrophy of choroidal vasculature and Bruch's membrane is found throughout the fundus, except in a small region of central macula, but extensive atrophy of RP and photoreceptors is found throughout the fundus, including the central macula. Patients with choroideremia present in first or second decade of life with nyctalopia and constriction of peripheral visual field. Visual field constriction progresses until only a small central residual field remains in the fourth decade of life. Loss of central vision occurs much later in 6 to 8 decades of life. Fundus abnormalities appear by second decade of life among patients with choroideremia and initially consist of fine paper-like RPE mottling in the mid-peripheral retina and posterior pole. Following this, hypopigmentation due to RPE atrophy and choriocapillaries atrophy occur, and this is most prominent in mid-peripheral retina and often occur in nummular zones as seen here in this clinical photograph, thus resembling gyrate atrophy at this stage of the disease. As a result of RP and choriocapillaries atrophy, the larger choroidal vessels become more distinctly visible in the involved zones. In later stages of the disease, the entire choroid atrophies and sclera becomes visible within the atrophic zones as seen here in this clinical photograph, and the involved zones progress centrally. And in the final stage, the entire fundus shows a diffuse white reflex from the exposed sclera as seen here in this clinical photograph, except the central macula where the choriocapillary still remains intact. The peripapillary region is also affected and the retinal vessels may become attenuated, but the appearance of the optic disc remain normal. On fundus autofluorescence, hypoautofluorescence is found in areas of atrophic RPE as seen in these two FAF images, and the non-atrophic areas show a speckled pattern of autofluorescence and hyperautofluorescence. Optical coherence tomography shows RPE disruption and thinning of ellipsoid zone as seen here in these two locations in these two OCT images, and cystoid macular edema may also be detected. Later, diffuse chorioretinal atrophy can be detected on OCT. Fluorescent angiography shows hypofluorescence in the zones of RPE and choroidal atrophy as seen here in these two fluorescent angiograms, with these being the corresponding fundus autofluorescence images and these being the corresponding ICG angiograms. Visual field testing shows ring scotoma and enlarged blind spot in well-established disease because of involvement of mid-peripheral and peripapillary retina respectively, and only a central island remains in later stages of the disease. Dark adaptation testing initially shows elevation of rod threshold, but later cone threshold also becomes elevated, and full field ERG shows attenuation of both scotopic and photopic amplitudes, with scotopic amplitudes being affected more severely than photopic amplitudes, and in later stages of choroideremia, the ERG becomes unrecordable. So if we compare Gyrate atrophy with choroideremia shows X-linked mode of inheritance, earlier onset of symptoms and signs, normal serum ornithine levels, but no increased incidence of myopia and cataract. Female carriers of choroideremia usually show a milder form of the disorder, typically in the form of pigment alterations, most prominently in mid-peripheral retina, which is known as moth-eaten appearance, as seen here in this clinical photograph. Often radial bands of hyperpigmentation are found extending peripherally from the mid-peripheral retina to the ora serrata, as seen here in this clinical photograph. Carriers of choroideremia are generally asymptomatic with well-preserved visual acuity, and full-field ERG visual fields and dark adaptation are usually normal, but these may show abnormalities only much later in life. In contrast to carriers of X-linked retinitis pigmentosa, carriers of choroideremia are generally asymptomatic, whereas carriers of X-linked retinitis pigmentosa often have symptoms. Fundus typically shows abnormalities in carriers of choroideremia, but full-field ERGs remain normal till late in life in these individuals. On the other hand, in carriers of X-linked retinitis pigmentosa, ERG abnormalities are almost invariably found even if fundus appearance is almost normal, and hyperopia or emmetropia is usually found in carriers of choroideremia, but myopia is common in carriers of X-linked retinitis pigmentosa. A phase 3 clinical trial has been conducted for gene therapy in choroideremia, and 14 to 18% of recipients in this trial showed an improvement in 10 or more ETDRS letters at 12 months. But this therapy has not been approved by FDA because only very few recipients in this trial showed an improvement of 15 or more letters. And cystoid macular edema, when detected in a patient with choroideremia, should also be treated. Bietti crystalline dystrophy is an autosomal recessive disorder due to mutation in CYP4V2 gene. It is most commonly found among East Asians, and histopathology shows intracellular lipid crystalline inclusions due to accumulation of cholesterol and cholesterol esters. Patients usually present by third decade of life with visual acuity loss and nyctalopia, and on fundus examination, atrophy of RP and choriocapillaries can be detected, most prominently in the posterior pole. In addition, numerous small glistening yellow-white crystals are characteristically found all over the fundus, as seen here in this photograph. One-third of patients with Bietti crystalline dystrophy also demonstrate crystals in the superficial stroma of peripheral cornea. Fundus autofluorescence shows sharply demarcated areas of hypoautofluorescence in the regions of RP and choriocapillaris atrophy, and fluorescent angiography initially shows transmission hyperfluorescence in areas of RP atrophy, but later shows hyperfluorescence when choriocapillaris also atrophies. Optical coherence tomography shows hyperreflective opacities in all layers of the retina, as seen here in this OCT image, outer retinal tubulations, and progressive chorioretinal thinning. Visual fields show constriction of peripheral visual fields as well as central and pericentral scotoma, and full field ERG can range from normal to undetectable response. Gene therapy has been attempted in clinical trials with positive results in patients with Bietti crystalline dystrophy. Differential diagnosis of choroidal dystrophies include X-linked retinitis pigmentosa, in which bone spicule pigmentation are characteristically found along with early loss of visual acuity, albinism, in which nystagmus and iris transillumination defects are present but nyctalopia and ERG abnormalities are not found, myopic chorioretinal degeneration, which does not have nyctalopia at least early in life, Kearns-Sayre syndrome, which has a mitochondrial inheritance pattern in which, in addition to pigmented retinopathy and generalized atrophy of choroid and retina, ophthalmic features include progressive external ophthalmoplegia and ptosis, along with systemic features, thyroidazine toxicity, Stargardt's disease, and pattern dystrophies. To recap the salient points, choroidal dystrophies are inherited progressive bilateral and symmetric disorders which usually start with RPE disruption and atrophy and progresses to atrophy of choroid and photoreceptors. They are classified as regional or generalized based on the extent of the fundus involved. Central areolar choroidal dystrophy or CACD is an autosomal dominant regional choroidal dystrophy presenting in second to fourth decade of life with loss of central vision. Fundus examination shows RPE mottling in the central macula in early stages of the disease, and later a well-defined area of RPE and choroidal atrophy develops through which large choroidal vessels and later sclera become visible. Unlike Stargardt's disease, flecks surrounding the zone of atrophy are absent in eyes with CACD. Differential diagnosis of CACD include Stargardt disease, pattern dystrophy, cone dystrophy, North Carolina macular dystrophy, and geographic atrophy of age-related macular degeneration. Gyrate atrophy is an autosomal recessive generalized choroidal dystrophy due to deficiency of ornithine transaminase enzyme, which converts ornithine to glutamate. Patients present with nyctalopia in second to third decade of life with loss of central vision occurring much later. Patients develop well-defined zones of RPE and choroidal atrophy with scalloped margins in peripheral and mid-peripheral fundus. These zones coalesce and also progress centrally and peripherally over time. Treatment includes arginine-restricted diet and vitamin B6 supplementation. Choroideremia is an X-linked recessive disorder which presents with nyctalopia in the first or second decade of life with loss of central vision occurring later in 6 to 8 decades of life. Early on, there is stippling of RPE in mid-peripheral fundus and posterior pole. Later, nummular areas of RPE and choroidal atrophy develop in mid-peripheral retina, which may resemble gyrate atrophy, which gradually progress to involve the entire fundus, which appears white in color due to exposed sclera, except in the central macula, where choriocapillaris remains intact till the very late stages of the disease. Unlike gyrate atrophy, choroideremia is an autosomal recessive disorder having an earlier onset and normal serum ornithine levels. Female carriers of choroideremia typically show pigmentary changes in the mid-peripheral fundus but remain asymptomatic with normal ERG till late in life. In contrast, carriers of X-linked retinitis pigmentosa typically have an abnormal ERG and are often symptomatic even if fundus appearance is normal. Pardon me, this will be X-linked. Bietti crystalline dystrophy is an autosomal recessive disorder Patients usually present with nyctalopy and loss of central vision by third decade of life. Small glistening yellow-white crystals are seen in the fundus, along with atrophy of RP and choriocapillaries, which occurs most prominently in the posterior pole. One-third of patients with Bietti crystalline dystrophy also show crystals in the superficial stroma of peripheral cornea. Differential diagnosis of diffuse choroidal dystrophies include retinitis pigmentosa, albinism, myopic chorioretinal degeneration, Kearns-Sayre syndrome, thyroidazine toxicity, and advanced cases of Stargardt disease and pattern dystrophies. Thank you for listening.